Athletes who aim to change their body composition generally focus on gaining muscle, losing body fat, or achieving both. In certain situations, such as recovery from disordered eating, some athletes may need to gain both muscle and fat, but the main goal for most is to either increase muscle or reduce body fat. The first step toward changing body composition is estimating daily caloric requirements. Though calorie is commonly used, the accurate term is kilocalorie. An athlete's calorie needs are determined by multiple factors, including genetics, body weight, body composition, training regimen, and age. Additionally, children and adolescents require calories to support growth and development. The basal metabolic rate is the largest contributor to total energy expenditure, accounting for approximately 65% to 70% of daily energy needs. The basal metabolic rate represents the calories necessary for essential body functions such as breathing, blood circulation, digestion, and kidney function. The basal metabolic rate is measured after a 12 to 14 hour overnight fast, with the individual resting, lying down, and awake but motionless. Resting metabolic rate is a similar measure that does not require fasting and is therefore easier to measure. However, resting metabolic rate is usually 10% to 20% higher than the basal metabolic rate because of the increased energy expenditure from recent food intake or earlier physical activity. Several factors influence basal metabolic rate and resting metabolic rate, with fat-free mass explaining roughly 70% to 80% of resting metabolic rate variation among individuals. Other factors include age, nutritional status, genetics, and endocrine factors such as thyroid hormone levels. The energy used during physical activity is the second largest component of energy needs and is the most variable across individuals. The calories burned in physical activity increase with the frequency, intensity, and duration of both training and non-training daily activities. Physical activity typically contributes 20% to 30% of total daily energy expenditure, though this proportion may be significantly higher in athletes. The highest energy costs occur in long-duration aerobic activities performed by larger athletes, while skill and power sports performed by smaller athletes require fewer calories. The thermic effect of food, also known as diet-induced thermogenesis, is the rise in energy expenditure following a meal, which accounts for about 10% to 15% of daily calories burned. This includes the energy cost of digesting, absorbing, metabolizing, and storing food. To calculate the calorie needs, athletes may use various equations, including the Cunningham equation and Harris-Benedict equation. The Harris-Benedict equation estimates resting metabolic rate based on sex, body weight, height, and age, and can be adjusted with an activity factor between 1.2 sedentary and 1.9 highly active. However, it does not account for the effect of muscle mass on resting metabolic rate. The Cunningham equation, which includes fat-free mass, may be more applicable for athletes. The equation suggests that resting metabolic rate increases with lean body mass. The base value, 550, represents a general caloric need, and the factor of 22 means that for every kilogram of lean body mass, the body requires an additional 22 calories per day to support basic functions. So, individuals with more lean mass have a higher RMR than those with less lean mass. After calculating resting metabolic rate using lean body mass, an activity factor refines the estimate of daily calorie needs. For greater precision, metabolic equivalence (MET) values are sometimes used to estimate calorie expenditure during activity, with 1 MET equal to the energy expenditure of sitting quietly. Higher intensity activities have higher MET values. Another approach used by highly motivated athletes involves recording dietary intake over 3 or more representative days when body weight is stable. The average daily caloric intake during this time is assumed to match daily calorie needs. However, this self-recording method may lead to errors, as recording food intake can alter eating patterns. Many factors influence weight gain, with diet and training being controllable factors. The off-season is an ideal time for dietary adjustments aimed at gaining weight, as athletes are less likely to be affected by competitive pressures. To achieve gradual weight gain, a general guideline is to consume around 500 additional calories per day, which may be adjusted depending on the athlete's needs. Increasing portion sizes, meal frequency, and focusing on calorie-dense foods can aid in weight gain. To maximize lean mass gain, athletes should consume approximately 1.5 to 2.0 grams of protein per kilogram of body weight daily. Though a high protein intake can increase feelings of fullness, it can also support lean mass gains. Research suggests that higher protein diets are associated with a greater proportion of muscle gain relative to fat when paired with excess calories. Creatine monohydrate supplements are another effective tool for promoting lean mass gain. Additionally, regular nutritional guidance from a sports dietitian or nutritionist has been shown to improve weight gain outcomes, as athletes receiving dietary counseling gained in more total and lean mass compared to those left their own diets. For athletes aiming to reduce body fat, the goal is often to improve performance metrics such as speed or endurance. Maintaining a specific weight can also provide a psychological edge in competition. Research shows that low carbohydrate and low fat diets both result in weight loss, with total calorie intake and adherence being more important than diet type. Since dieting can reduce muscle mass, it is important to consume 1.8 to 2.7 grams of protein per kilogram of body weight daily to preserve muscle, while maintaining a moderate calorie deficit of about 500 calories per day. To be effective long-term, diets should be individualized, sustainable, and include consideration of lifestyle habits, medical history, diet history, and food preferences. Diets should also meet all nutritional needs to support training and performance. Studies have shown that consistent behavior therapy and support can improve long-term weight loss success. The classifications for overweight and obesity, defined by body mass index (BMI), are based on health risks. Overweight is defined as a BMI between 25 and 29.9, and obesity as a BMI of 30 or higher. While BMI is commonly used, it does not distinguish between fat and muscle mass, which can lead to an overestimate of body fat in muscular individuals. For more accurate assessment, measurements like skin folds or dual energy X-ray absorptiometry (DEXA) should be used. Obesity has complex causes involving genetics, environment, social, cultural, metabolic, physiological, and behavioral factors. Treatment can involve dietary changes, increased physical activity, behavior therapy, medication, and surgery. Initial weight loss goals for overweight and obese individuals are often set at 10% of their initial weight over 6 months. Rapid weight loss usually involves methods that result in faster weight reduction than typical calorie reduction and exercise alone, often used by athletes in weight class sports. These methods can include fasting, voluntary dehydration, use of diuretics, sauna, salt restriction, and excessive clothing, excessive spitting, self-induced vomiting, laxative use, and the use of thermogenic aids. These practices can lead to dehydration, fatigue, muscle cramps, hormone imbalances, electrolyte issues, kidney failure, and in extreme cases, death. Strength and conditioning professionals should recognize signs of these behaviors and work with the athlete's coaching and medical staff, ensuring all steps are documented. Athletes who struggle to make weight safely may need to reassess their weight class. Managing body composition safely involves a personalized approach to diet and exercise, calorie adjustments, appropriate protein intake, and adherence to safe practices allow athletes to pursue body composition goals without compromising health or performance. Eating disorders such as binge eating disorder, anorexia nervosa, and bulimia nervosa are serious mental health conditions affecting individuals across genders and ages, increasing the risk of mortality. Those with these disorders often experience other psychiatric issues, including anxiety, mood disorders, impulse control issues, and substance abuse disorders. Research indicates a heightened prevalence of both disordered eating and diagnosed eating disorders among athletes compared to non-athlete populations. Athletes involved in weight class sports like wrestling, lean emphasized sports such as cross country running, and aesthetic sports like gymnastics may be especially vulnerable to developing disordered eating or eating disorders. So, disordered eating behaviors may include restrictive eating, fasting, meal skipping, and using diet pills, laxatives, or diuretics. However, these behaviors do not meet the full diagnostic criteria for an eating disorder. Eating disorders are complex and multifactorial, requiring a team-based approach to treatment. Strength and conditioning professionals play an important role in recognizing the signs of these disorders and providing referrals to medical, psychological, and nutritional experts who specialize in eating disorder treatment. Anorexia nervosa is defined by a distorted body image and an intense fear of weight gain or becoming fat, leading to severe calorie restriction and considerable weight loss. Those with anorexia often place an extreme emphasis on weight or body shape, but do not acknowledge the severity of their condition. Many also engage in ritualistic behaviors like frequently weighing themselves, cutting food into small pieces, and portioning meals meticulously. Anorexia nervosa has two subtypes: restricting type does not engage in binge eating or purging. Binge eating or purging type regularly engages in binge eating or purging. The typical age of onset for anorexia nervosa is 19, with a lifetime prevalence of 0.9% for females and 0.3% for males. Only about 33.8% of individuals with anorexia nervosa receive treatment. It is worth noting that anorexia has the highest mortality rate among mental health disorders. Symptoms of anorexia nervosa include bone thinning, osteopenia or osteoporosis, brittle hair and nails, dry and yellowish skin, growth of fine hair, lanugo, anemia, muscle wasting, low blood pressure, heart damage, and in severe cases, multi-organ failure. Previously grouped under a broader category, binge eating disorder now has its own classification. Binge eating disorder involves episodes of uncontrolled eating occurring at least once weekly over a period of 3 months, where individuals consume significantly more food in a short time than typical. These episodes are often marked by rapid eating, eating until uncomfortably full, consuming large amounts when not hungry, eating alone due to embarrassment, feelings of disgust, depression, or guilt afterward. Unlike bulimia nervosa, binge eating episodes are not followed by purging, often leading to overweight or obesity. The average age of onset is 25, with a lifetime prevalence of 2% for men and 3.5% for women. Many individuals with binge eating disorder experience physical and psychological challenges and often feel embarrassed or ashamed, leading to secretive eating behaviors. Bulimia nervosa is characterized by recurring episodes of consuming large amounts of food in a short period, followed by compensatory purging behaviors such as vomiting, excessive exercise, laxative use, or diuretic use. These behaviors occur at least weekly over 3 months. People with bulimia tend to feel out of control during binges, are typically of normal weight rather than underweight, and often feel unhappy with their weight or body shape, coupled with a fear of gaining weight. Aninoric. The average onset age for bulimia nervosa is 20s with a lifetime prevalence of 0.6%. Symptoms of bulimia nervosa include sore throat, swollen salivary glands, worn tooth enamel, acid reflux, gastrointestinal issues, dehydration, and electrolyte imbalance, which can lead to heart complications. Avoidant restrictive food intake disorder is marked by a lack of interest in eating, avoidance based on food's sensory properties, or concern about the negative effects of eating. This disorder leads to significant weight loss, nutritional deficiencies, dependence on supplements or feeding tubes, and social challenges due to restrictive eating. Pica is diagnosed when individuals consume non-nutritive substances for at least a month, such as clay, ice, hair, or chalk. This behavior is associated with issues like electrolyte imbalance, intestinal obstruction, and gastrointestinal problems. Testing for anemia is recommended as pica is often linked to iron deficiency. Rumination disorder involves repeatedly chewing, reswallowing, or spitting regurgitated food and must be unrelated to other medical conditions to qualify as a disorder. It can occur alongside other eating issues or disorders. Strength and conditioning professionals are not responsible for diagnosing or treating eating disorders. Instead, they should be knowledgeable about the symptoms of each disorder and able to refer athletes to appropriate professionals such as doctors or dietitians if concerns arise. Abnormal eating and amenorrhea alone do not indicate an eating disorder. A qualified professional should handle any diagnosis and treatment plan. Strength and conditioning professionals play a crucial role in recognizing potential signs of eating disorders and encouraging athletes to seek help, while understanding that treatment and diagnosis fall within the scope of mental health and medical professionals.